Our next speaker is Joellen Condon. Ms. Condon is the Managing Director of the American Diabetes Association Education Recognition Program, and she's also a registered dietitian and certified diabetes educator. She has over 20 years of dietetic clinical practice and departmental management experience. Prior to joining the ADA, she had a private practice as a dietitian and was in network with 8 insurance companies. Her practice provided diabetes prevention and treatment-focused services with a special focus on insulin pump therapy and continuous glucose monitoring, along with diabetes and pregnancy, diabetes, chronic kidney disease, and end-stage renal disease. Without further ado, please help me in welcoming Ms. Joellen Condon. Thank you.
Thank you. Boy, that was a hard act to follow, those two ladies. One thing, though, before I get into diabetes education, I would like to announce is that the ERP program, we are building out a DPP platform that we hope to have ready by December 31st. Do we have anyone in the room that is in an ERP program or who has heard about chronic diabetes? Yeah. So we have a diabetes education electronic charting system that we provide to our programs free. It's HIPAA and high-tech compliant, and we're building that out to capture the DPP class sessions and to produce that report that CDC requires. We're also building it out to generate progress reports. So as programs go throughout the year, they don't get to that 12 months and they're shocked because they're not meeting those CDC requirements. You're the first group to hear about this because we got the final go-ahead last weekend to actually build it, even though we've been working with the programmer. So there will be more information coming out on this. So if you are looking to do a DPP, I'll switch places. Okay. All right. So now to switch gears. So my topics, they asked me to cover quite a few topics. So I'm going to do a high fly over these topics and then open it up to questions. So diabetes self-management education, and then diabetes self-management or diabetes support program. That seems to be the question a lot of folks have nowadays. What's the difference and how do they complement each other? Because they really do when done correctly. So a lot of folks I've heard call the diabetes self-management education programs, they'll call them the clinical program, and then they call the support programs the community program. So I don't know if you've heard that in your areas, but that's what we're hearing at National. So the clinical programs, these are based on the national standards that first came out in 1984. As you know, Medicare has 2 accrediting organizations that have to accredit the programs in order to be reimbursed, and that is ADA and AADE. We're actually also looking at the standards. We've got a work group together, and the standards will be updated next year. This is usually done every 5 years, whereas they said with DPP, that's every 3 years. So what are the standards defined? Just like with DPP, like Pat said, they define quality. And with DSME, they define it through structure, process, and outcomes. We're not going to get real deep into this, but we'll look at that. Also, recognition or accreditation is reimbursement. It assures reimbursement through Medicare and many other private insurers. DSME is also very individualized. It's not a package program, but it's really looking at individual needs. So there's 10 standards. The first 5 define structure, and the standard title basically defines what the standard is. With an hour, we're not going to get real deep into this, but I'll certainly take questions at the end. 6 through 8 are the process. And the process we call the DSME cycle, which I'll give you a visual here in a second. And then the last 2 are the quality, which are so important. And some programs don't realize this because that's how you get increased referrals. If you can't show those outcomes, you're not going to get your referrals. And especially with reimbursement going to the reimbursement for outcomes versus pay for services. That is huge. And we're starting to see This year, a number of programs that closed over the past 3 years are reopening because organizations, reimbursement is changing. Who's heard of the hospital readmission reduction program? Right. That is driving a lot of DSME programs. What that is if a patient is readmitted within 30 days with specific diagnosis, which diabetes is not one, that hospital, if there's excessive of that, their Medicare reimbursement is reduced up to 3%. And that 3% is not just for patients with those diagnoses, it's that total Medicare bill. So that is a lot of money for many hospitals. And so there's 7 diagnoses now. CABG is coming on next year. And how many people who get CABG, coronary artery bypass graft, have diabetes? So it's really driving programs is what we're seeing. So the initial comprehensive DSME cycle, that was the process, this is basically what it looks like. This is the individualization. So DSME is not coming in and doing an incidental training or learning to give a shot, but it's coaching that person through their skills and then working that into their life, looking at what the barriers there might be or misunderstandings, and then continuing through the process. And then the other standards really build up the program. And what we find is our programs that are in trouble are not necessarily embracing these other standards, because if you don't look at your population and make sure you're providing a program based on what your population needs, timing, the education provided, just like they were saying with DPP, you're not going to be successful. So it's really knowing your population, having the resources, and then tracking and promoting those outcomes. As I said, what DSME is not, it's not that incidental training. It's not a clinic visit, although it can happen during a clinic visit, but it's not that just in and of itself. It's not a packaged program that's the same for everyone. It's very individualized, and it's not support groups, although most DSME programs do have support groups. So what's required to be recognized? First, the program has to be operating under the 10 standards. They have to take one person through that cycle of those blue dots, that comprehensive, which begins with assessing their needs, an education plan based on their needs and concerns. So there's 9 topic areas we talk about with DSMT, but everyone doesn't need education on those 9 topic areas. So you look at what they need, and that's what you provide them. That's a big misunderstanding we find is people think, oh, we got to check these 9 boxes for everyone. No, you assess those 9 boxes, and then you provide based on their needs. Then the program submits an application, and then they're recognized for a 4-year cycle. And during that 4-year cycle, they have to maintain adherence to the standards, and Medicare requires that we audit 70 of our programs annually. And when I say that audit word, a lot of people, they're like, oh my gracious, an audit. Actually, that's where we get our best practices, our templates, and our auditors. So an audit is not, if you will, a witch hunt. It's usually a very positive, experience. And what we find is programs that get recognition withdrawn, they're not really, it doesn't really hurt their feelings that much. A lot of them are just doing M&T, not DSME, or the staff has changed and they're just not interested. And that's doing people with diabetes no service if they're not really interested. So now we're going to shift gears into the program models and structures. What does a DSME program look like? So real quick, is a CDE or BCADM or medical director required for a recognized program? Who says yes? Who says no? Okay. So a CDE or BCADM, which BCADM is a board-certified advanced diabetes management professional, they are not required to have a DSME program. And a physician is not required to be part of a DSME program. It's education. It's not evaluation and management, but it's education that's directed by a physician, but they don't have to be part of the DSME program. That's the big misunderstanding we find some folks have. The minimal educator requirement is a dietitian or a nurse or a pharmacist or that BCADM. And if that dietitian, nurse, or pharmacist is not a CDE, then they have to get 15 hours of diabetes continuing education each year. Programs can be single or multidiscipline. Best outcomes are seen with multidiscipline programs, but there's such a large population and such a need out there. If we required that, a lot of programs wouldn't be in existence. So if a single discipline or even a one educator program can show the outcomes, then they can absolutely have recognition because we want to serve the folks. And then program structure. So each program has one primary site, and some programs only have one site. Each program has a program coordinator. Sometimes that's one of the educators, sometimes that's not. And then off of that primary site, you can have additional what we call multi-sites. And multi-sites can have different educators, they can have a different curriculum, they can even do their own billing. And then any multi-site can have an expansion site coming off of it. And I call expansion sites road shows. So that's when you take the same educators, the same curriculum, and you just go to another location and deliver it. And then the billing is done by that multi-site. The one thing though, when programs are looking to expand is if you are a hospital multi-site, you can currently only expand out to other hospital locations. And what we've seen this past year is a lot of hospital outpatient programs want to go to maybe a physician clinic a couple days a week, but it's not part of that hospital organization. They can't go out there as an expansion site. They would have to go out there as another multi-site, and that site would have to do the billing. That's not an ADA requirement, that's a Medicare reimbursement requirement. So we would absolutely recognize you, but we don't want to set you up not to be able to bill. So the way programs are working around that is, especially large organizations with a lot of physicians' offices, they're even either transferring their recognition to one of the physicians' offices and expanding out from it, or multiple physician offices and then expanding out a few locations. Before I move on to this slide, does anyone have any questions? Because this usually brings questions. Yes?
What if you're a health system with clinics on campus that are under the same NPI or the same tax ID?
So that could be an expansion, yeah. And if you're a physician clinic, you can expand out to sites not associated with that physician clinic. It's just the outpatient hospital program. It's a Medicare outpatient hospital billing regulation. And actually we met with Medicare last Monday, and that was one of the barriers we addressed. The problem with some of the DSME barriers, they would actually take it back to Congress to change. Some of them Medicare don't even have the ability to change. Congress would have to change, which is a little bit discouraging, but there were a few things I think they'll be able to make some change on. Any other questions about those programs? Okay, so this is just a chart of what I just said about this multiple sites. Then DSME curriculum, the questions we get. Like I said, there's 9 topic areas, but everyone doesn't have to be taught on 9 topic areas. And then each of those topic areas have to have 4 things: learning objectives, content, method of delivery, and method of evaluating learning. Method of evaluating learning, some of the peer curriculums that are out there, that's the one piece that's missing from those peer curriculums, which we're going to talk about here in a second. So peer curriculums can be a base that you can adapt to meet what's required for the standards. But those four areas are what's required. So I guess I just gave that one away about the 9 topic areas. So now we're going to shift gears for the diabetes support programs or the community programs. These are typically peer-led, Usually they're in a community and they don't address the clinical aspects of diabetes. And an example of that would be, so a support program might work with someone to ask them, are you checking regularly your blood sugar? And if you're not, why not? Are there some misunderstandings? Can you not afford your strips? These support programs can help individuals learn and work through those barriers to getting supplies. The DSME program is the program that's going to teach them, how to test that blood sugar, but then what to do with those numbers. And often even how to adjust your medication, especially if it's insulin, and the order for DSME has allowed the educator to titrate to goal, the insulin. So diabetes support programs, any in these areas that you cover that you'd like to mention? Okay. So support programs also have been created to serve the uninsured or underinsured. Like I said, they're usually peer or community health worker led. They help individuals navigate the healthcare system, which can be very challenging, especially if you're not someone who's used to being in a healthcare system. They can also help access DSME, as DSME should help access support, because diabetes and lifestyle change is not a one and done. The more touch points you have, research shows, the better the outcomes. And then, like I said, ongoing support post DSME program. And I like it to Marie Osmond or your Kirstie Alley, how many times have we seen them cycle through their weight loss or their behavioral change? It's not easy. So there needs to be that ongoing support to help with that. So in your handouts, there is a sheet, a multicolored sheet. And I developed this because people would call us and they'd be like, well, can a Stanford program be recognized? Or just different questions that you could tell there was some confusion around what these different names of programs were that were out there. So let's just start and look at the top. Look at the acronyms, DSMP, DEEP, ERP, DEAP. Someone coming in for the first time, you'd be like, what? What is all this? So let's look at the next row. DSMP, or the Diabetes Self-Management Program, is actually a curriculum. It's a turnkey curriculum that programs can use. So it's actually a curriculum, same as DEEP, it's a curriculum. ERP, which is ADA's Education Recognition Program, and DEEP, which is AADE's Diabetes Education Accreditation Program, those are the accredited or credentialed DSME programs that Medicare reimburses. DSMP, this is the CDC programs that have to use the Stanford curriculum that are now available out there. Everyone with Diabetes Counts is a program that Medicare has actually launched that has to use one of these two curriculums that serves the underserved Medicare community. So when Medicare took EDC, everyone with diabetes counts nationally, there was really a lot of uproar by the ERP programs. We heard it by CDEs, and I think that was because Medicare didn't get out in front of it. They didn't let people know what these programs were being developed for, because the ERPs were like, well, you're competing with these. And in some locations, unfortunately, that did happen. But we immediately contacted CMS and said, whoa, wait a minute, what's going on here? And CMS would let those folks know, move out of that small community, there's an ERP there, but go to the uninsured and the areas where it's really the EDCs needed. If they'd gotten out in front of it, I think things would have been a lot smoother. And hopefully now there's not that competition. So then if we go back again to our columns, the first column, actually all the columns except for the pink columns can be peer or community health worker delivered. They don't require a licensed professional. They can be delivered by a licensed professional, but they certainly don't require it. These other columns are not reimbursed by Medicare, but EDC is actually funded 100% by Medicare. And then the other columns don't address the clinical, like we were saying, the titrating of the insulin, the giving of the injection. Those things you need a licensed healthcare professional to do. Not to say one is more important than the other. They're all important. And the fact that they need to work together is key, really, really key. So now we're going to switch again. Like I said, we're going to be switching gears because they want me to cover a lot of topics.
Do some clarification.
Sure.
For Iowa.
Yep.
On your chart. We are CDC 1305 funded in Iowa, but we do not use the Stanford program, although we could. Let me get it. We have 1305 funding in Iowa. Stanford is a program that's available to us to implement as is an ADA program or an AADE program. We have an additional certification in our state that provides for Medicaid reimbursement. So I'm a little concerned about the blue column. I don't know, maybe some of the other states that are on the call today are set up this way. But in Iowa, we have an additional certification that we call certification versus recognition or accreditation that provides for Medicaid reimbursement, but it's not specific to Stanford. So, right. Yeah, I just wanted to clarify here. I don't know in the other states if this might be the way they do things, but in here, I just didn't want to confuse anybody that had a state certification as well as a ADA or AADE recognition. And you know what I'm saying?
No, it's very confusing.
Okay. Because, well, yeah, I just don't know if that's accurate. I know that's not accurate to us as far as the 1305 state. So, yeah, if there's any questions or confusion. But most, if not all the programs, well, not quite all, but most programs have a national recognition, either ADA or AEDE, and then they have a state certification in Iowa. So,
Yeah, let me give it a little clarity around that. See, that's exactly my point. It's very confusing. So the 1305 are usually peer-led, and make sure I'm answering your question.
yeah, we're not.
But there's the ABA and AADE recognized. So are you talking about the recognized program?
I think that Iowa has its own state certification, so and it's a little different here, but we can move on to because this slide is a little off for Iowa. So it might be applicable for other states.
So this isn't talking about the recognized programs. This is talking about specific peer-led. A lot of states, in addition to being recognized or credentials for Medicare, they also have state credentialing, and these programs in this column also have to have that state credentialing for their Medicaid reimbursement. Am I tracking with
That's correct.
Yeah.
But we have 1305 funding, but it's not specific to Stanford, and it is a medical program.
Okay, is it to increase your number of ERPs and DEAPs?
That is one of our goals. Yes.
Yes.
For increased access, and that would be through ADA or AEDE programs as well as other states.
So I need to add state specific. I need to say that some states. I need to add that to this chart and to help clarify it. Yeah, some states don't even have it, but some do. Yeah, they have that additional. That was a great.
Did you have the word Stanford on the chart?
All right.
All right, thank you.
No, thank Thank you. Like I said, it's confusing. It is very confusing to folks, and me sometimes too. Any other questions? All right. So reimbursement, we're going to do a flyover, but if there's questions at the end, please ask them. So even with DPP, the CDC requirements for a DPP program to be recognized, that's one set, but then you're also going to have to look at what Medicare is going to require for them to reimburse you. So just like with DSME, we have the requirements based on the standards, but then Medicare has additional requirements, like that outpatient hospital program where it could be, and those 10 hours and 1 hour as one-on-one. That's Medicare. That's not the standard. And I think that's what you're going to see with DPP once the final ruling comes out with that. So the only requirement of a physician is with Medicare is to make the referral into DSMT. So a question we get a lot, can a podiatrist or a hospitalist or a wound care physician make the referral into DSMT? And the question is no, not unless they're managing that person. And the language says diabetic condition. So people come back and they say, well, they're managing their diabetic wound, etc. Medicare is talking about their blood sugar management, not specifically that acute or chronic illness due to diabetes. This is one of the things we talked to them about last Monday, and I noticed they were taking a lot of notes and asking a lot of questions when we got to this topic. Hopefully, fingers crossed, we'll see some change. It's actually a really exciting time to be into diabetes education because Medicare is asking for recommendations to remove some of these barriers. The DSME coverage hours, most folks in the room probably know this, but you have to be a Medicare Part B beneficiary. So if you don't have Part B, it's not covered. It's 10 hours within the first 12 months after that first DSME encounter. Some people think it's the 12 months after the diagnosis. It's not. It's 12 months after that first DSME encounter that was reimbursed by Medicare. So if they received DSME under another insurer and then they became Medicare eligible, they're still eligible. It's a once-in-a-lifetime benefit. So if someone comes in currently and gets 2 hours, and sometimes people don't even realize what they received, and then let's say 5, 7 years later they're starting insulin and they come back in, they only have those follow-up hours. They don't have the 10. Again, that's another thing that we addressed with them, Medicare last week, is that use it or lose it. Is there anything they can do around that? Or can they do anything around maybe the way M&T is? You know, there's that second referral same year. Can they change DSMT to have, so that the second referral received, they can get more hours that same year? Usually there's only 1 hour allowed as one-on-one and the other 9 are group. But there again, the physician, the referral can reflect a need for more of those hours as one-on-one, and a patient can receive them. Okay. So how can you get more of those 10 hours as one-on-one? If the physician indicates on the referral a barrier to group learning, more of the one-on-one for insulin training, or there's no class available for 2 months. So we'll get the question, well, we're just going to set our program up so we just do one-on-one, and there'll never be a class available in 2 months. That won't work. The program has to be built where most of the participants go through with 9 hours of group and 1 hour of one-on-one. So these are just the billing codes. Most folks have already seen them probably. DSME is billed in 30 minutes with no rounding. you have your GO 108, which is 101, GO 109. These are the national average reimbursement rates per 30 minutes. Participants do have a 20% copay, which is unfortunate. And this is the link for the physician fee schedule if you want to see what the reimbursement is in your area. So we got an interesting question. Actually, we did a symposium in North Carolina last month. And someone said, well, we started waiving that 20% copay. No, actually, they said they started providing their DSME programs free, and their compliance officer told them, no, you can't do that because that's enticement. So I reached out to CMS and I said, is that enticement? And she said, well, not necessarily. So if you're providing DSME free because you're serving your population, you want to save costs, no problem. If you're providing it free, well, it's free if you start seeing me as your provider, that's enticement. So as long as if you're providing it free for everyone or waiving that 20% with everyone for everyone, and it's not an enticement-backed decision, you should be fine. So DSMEs at FQHCs, anyone in here at working at an FQHC? Okay, so this strange thing was, I remember when I started at ADA 3.5 years ago, we had very few FQHCs that were recognized. But FQHCs actually get reimbursed higher. They can be reimbursed higher than non-FQHCs. The thing about FQHCs is they will only reimburse separately if the DSMEs provide it one-on-one. So they don't even reimburse for group. It has to be one-on-one. Just like other programs, it can't be provided, or it will not be reimbursed on the same day as an MNT visit, which is medical nutrition therapy. It also won't be reimbursed on the same day as a medical visit. So FQHCs have a category of medical services. A primary care visit is a medical service. A DSME visit to them is a medical service. So they won't reimburse for a patient to come in and see their primary care on the same day as DSME. They're only going to get one reimbursement rate. But they will reimburse for DSME on the same day as a mental health visit. So if I was at FQHC and trying to get them to let me start a program, the first thing I would ask is how many of our mental health patients have uncontrolled diabetes, and schedule them the same day as they come in for that mental health visit. And then once they start seeing the positive outcomes, it starts to build. So these are the reasons.
Previous slide. You have the microphone over. The other venues are having a hard time hearing.
Okay, thanks. Yes.
So on the, I mean to the question that you advised for.
Oh, okay.
So on this particular slide, for instance, in our hospital, we're a critical access hospital, and so a clinic that might refer to it is a rural health designation. So it's my understanding that they have a rural health visit that day, and for instance, they might refer the patient to me for insulin education. So I can't go ahead and bill that same day that they had a rural health visit, is my understanding. Does that fall under the same guidelines with the FQHC? Okay.
So I am not sure if Matt had that question. Rural health clinics, though, are not reimbursed separately for DSME.
Well, our program is through our hospital. So we happen to be, we're in a rural area. So that kind of changes some of the rules right there because of the fact we are rural. And so we're a critical access hospital, but then a clinic that we work with very closely has a rural health designation, meaning that their reimbursement is different from Medicare. They're reimbursed at 101%. So it's been my understanding of looking through the guidelines that, for instance, if the doctor wants to start someone on insulin that day and they want them to see me the same day that they've been in for their clinic visit at the rural health clinic, I cannot also see them that same day and bill for it because it's already been billed to the clinic.
That is a great question. So, and I don't know the answer, but send me an email and I'll send it up to my Medicare contact because it's a good question. I'm not even going to answer it because my gut might not be the correct answer. Rural health clinics
like I said, cannot provide DSME and bill for it, but she's not a rural health clinic. So she's asking, can they see their physician there, and then we can provide DSME. I've never seen any language that addresses that, so I don't want to answer it. But I will tell you this, if you are a primary care office and a patient comes in and gets an E&M visit with their doctor, with that doctor's NPI, and your DSME program is using that doctor's NPI to bill on behalf of the program, you can bill and be reimbursed for both of those, for an E&M visit and a DSME visit on the same day. So because we're talking about rural health clinic, let me ask them. And then when I find that answer, I'll send it to some of the organizers that we get out to everyone. But that's a great question. Was there another question?
Yes, no, it's time. Can we just wait to the end to do other questions?
Okay.
We're starting to run out of time.
Okay, I'm known for that. Sorry about that.
Yeah.
Okay, so these are the billing codes and the reimbursement rate at FQHC. So the codes have what we call a modifier on them. So you have your you have your G0108 and your G, which is the only code you build. You can't build G109 because it's the group. But then when you do the bill, you also have this other code. This other code indicates if the patient is an established patient or a new patient. So if they're a new patient, it's $215 for that visit, whether that visit's 30 minutes or 2 hours, because they reimburse on a day rate. If they're an existing patient, it's $160. So here's the question I get. So if they're a new patient, how could they be a new patient and be getting DSME? Because when they see their physician first, well, maybe their physician is not part of that FQHC, so that's where they might be a new patient coming in with that. Another thing I hear is claims will be getting denied because when you do that bill for your G0108, let's say they come in for 2 hours of G0108, so that's 4 units. And then programs are putting 4 units also for that G0467, and the claim gets denied because there's only 1 unit for the G0467 or G0466 because that's the day rate. So you can only build 1 unit of that. And the reason why they're still requiring the 4 units of the G0108 is because Medicare is still tracking that they only get those 10 hours in that first year or 2 hours in follow-up years. DSME via telehealth, this is a hot subject right now. So in your packet, there is a booklet or a pamphlet that CMS has actually published online, and it shows you the types of sites, who can provide and be reimbursed for DSME, eligibility site lookup, billing codes, and requirements. This is the pamphlet. We're not going to go through it, but this is a gem. I will tell you that once you get a chance to really look at it. It's online, it's electronic, especially if you want to look up and see if you're in an area where you can be reimbursed for telehealth. You have the links you can just click on. Telehealth has to be real time, so you have to be able to see and hear each other real time. And there's only the exception if someone's in Hawaii or Alaska, and we're part of this BIPA program that was done 10 or so years ago. So you'll be able to hear each other and see each other real time. So the big question we get is, oh, that's perfect, we'll just do Skype. So again, reached out to Medicare, and they said, well, Skype meets that real time seeing and hearing each other. It's not a HIPAA compliant platform. So what I would recommend is, if you're looking at telehealth, partner with a physician clinic that's already doing telehealth, so they have the equipment, because that's where your cost is going to be if you try to do something via telehealth and start from ground up, unless you get some grant funding. With telehealth, a minimum of 1 hour the first year has to be in person for injection training. So not just for insulin, but you've got your Viatis and your different ones now for injection training. So programs will say,
well, that's a barrier because my telehealth site's 3 hours away. Well, maybe every 6 months you go there and you see your injection training folks. You have a class that day. You don't necessarily have to go out there every month, every 3 months. Medicare does not define that, just within that first year. Telehealth has 2 sites, which this is in your pamphlet. The originating site is where the patient sits, and they can actually bill. FQHCs can be an originating site where that patient's sitting. There's also distant sites. So that's where actually the educator is sitting. FQHCs cannot be a distant site. And there's a lot of FQHC guidelines. My thought behind that is probably FQHCs have to serve their community, so they can't be serving distant communities. I'm not sure, but it is a regulation they have. Again, that pamphlet has the site links. Here they are again. Distant sites, they can bill for hosting. These are where your educators sit. It's the same GO 108, GO 109. They just have that GT modifier on the end when you're billing. It's the same reimbursement as just it was in person, so there's no difference. The originating site where that patient's sitting can also bill a hosting fee. You've got the code there for it. In 2015, it was $25. I think it might spawn up a little bit. But at the site where the patient's sitting, you don't have to have a healthcare provider. It could just be a facilitator that's setting up the system that the telehealth could be provided on. And most programs that do it and do it really well, they might have a rolling cart with door 1. They open door 1, show them this way. The educator is actually talking through. I talked to one educator that does it via telehealth, and she said, the equipment now is so good, when you're looking at injection sites, you can even zoom in to see, if they've got if they're hitting the same spot and they're starting to get the fat build up from injecting in the same spot. Again, there's that 20% copay, unfortunately. And the reason why DSME has a 20% copay is, as Pat Schumacher was saying, that United States Preventative Service Task Force has not evaluated DSMT. So they've not rated us an A and B. So they're not saying we're not rated A or B, which just never been evaluated. So I talked to advocacy about this. I'm like, we need to get busy. They're like, this is a 2 to 3 year process to approach that task force and get evaluated. And I'm going to say on them, low utilization of DSME. Actually, a lot of the things they were saying about DPP are great recommendations for DSME to help with your utilization. Most of us have seen these numbers. Private insurance is less than 7% of the folks within the first year of diagnosis get DSME. Medicare, less than 5%. And it's not always the barriers, but the physician referral and the physician encouraging, and we've even heard physicians requiring patients saying, I'm not going to write your prescription unless you come to DSME, some of the pediatric programs. But that physician support is really one of the key things for folks following through to the DSME program or completing it. So these are some of the main barriers we've seen: low referral, low patient efficacy, that copay, and then inconvenience in transportation. But there again, that's where a program, you really need to look at your population and as much as you can, go to them, time your services around the bus schedule, etc. Or if you could even go out to senior centers, if your model of your program allows you. The solutions, again, those bubbles that came around supporting, those blue bubbles, if you're really looking at your program, you should be able to get things set up. What we typically see is once a physician's office starts getting that positive outcome, you're going to be busy. Physicians, a lot of them only have about 15 minutes with their patients. They don't have time for all those questions. A lot of primary care, programs will ask me, well, how do you know which physicians to target? Your pharmaceutical reps. they know who's they're starting on insulin and these other medications. Really partner with your pharmaceutical reps to find out who to target if you've got low referrals. And that's all I have. Any questions?
We do have some questions that have been coming in through the chat function, so we want to make sure to acknowledge those. One of the first questions that we had from earlier in your presentation, you mentioned the chronicle reporting for DPP will be available December 31st. Is that 2016?
It is. Well, the build has to be done. So January, we hope to launch it because a lot of programs, as they were saying, they have to be up and functioning for a year to get CDC pending recognition. So we want to have it ready January so programs can start putting their outcomes in it. So the programmer has not given me the prototype, but I gave him the prototype what I want it to look like. And if the build does, he is able to build it out like that, it's going to be very easy for the educator to input as they're educating, you know, the attendance, the weight loss, the minutes. And then on the back end, it's going to create that CDC report.
Thank you. And currently, Medicare does not cover pre-diabetics to attend DSME classes. Are there plans to change this?
No, that's your DPP. But that's where the DSME programs are creating DPP. That's why we're building out Chronicle, because our DSME programs are adding that arm to their program.
Next question, to prevent denial of claims for DSME from Medicare, how do we determine if a Medicare patient has been charged for their lifetime benefit for DSME?
So that is a very good question. Unfortunately, there's not a lookup. Medicare does not have a lookup. You can contact Medicare. What some programs report doing is they have a standard form that they give their patients, and they call your insurance company and see your coverage, or with Medicare, see what you have left. So what some programs will do is they'll bill those first 2 hours, and then that third hour is where the rejection comes if they've had it before. But unfortunately, right now, there's not a lookup.
And why is DSME so limited for coverage as in hours, and DPP has extensive coverages? It seems as though a person would need additional help after being diagnosed.
Right. So when DSME was first, when Medicare first started covering it in 2000, the coverage it has then is what the coverage it has now. And to get additional hours, that's dollars. So that's Congress.
And another question related to DSME and the individualized care and the disparity between other facilities such as FQHCs and what they're allowed to bill for. Is there any way to change that, or are they looking to have more consistency across settings?
So I have not heard that Medicare is, because FQHCs and rural health clinics, they have specific Medicare regulations around those type of facilities. And I think we're going to even see some more specifics around telehealth, what's based on what Medicare is saying. So that's what's challenging. You know, with Medicare, when you go and you look at the DSME reimbursement guidelines, so you've got those, but then you've got the guidelines around these different entities. That's some of the barriers we talked to them about, but I don't know that Medicare alone can change those. But also to address the DSME hours, we did talk to them, and they seem like they might be able to do something about that use it or lose it of the 10 hours. So maybe patients can extend it out over their lifetime, but until that announcement comes out next year, that ruling, we don't know, unfortunately.
All right. Another question regarding, is there an exception for patients on only oral diabetes therapy?
An exception for patients on only oral?
I'm not 100% sure what that means. It's just a question we received.
You know, I'm wondering if that's with telehealth, because with telehealth, if you're on an injectable, you have to have that 1 hour. And so something that's been buzzing around the community, diabetes community, is the way the language is, it says patients must have 1 hour for injection training. It doesn't say patients on injectables have to have 1 hour for injection training. So that's what programs are asking. Is it for everyone or just people on injections?
And that's another thing we address with Medicare, that they give clarification. If you look at the original ruling back in 2000, it's just for patients on injectables. But what the public looks at doesn't define that.
With the platform that's being released for Chronicle, are we required to use the Chronicle database or other ADA programs if we have an EMR that has the same information?
You are not. So we are actually building it out that it will be available for ERPs and for non-ERPs, because you have a lot of programs on DPP that couldn't be an ERP because they're just not structured like that. So if ERPs can just use the DPP or not use the DPP or use, it's going to be open to either way.
And can you readdress transfer from hospital-based programs to clinic-based? Clarify if other clinics service outreach under primary and who can bill?
So, yeah. So the hospital program, so the hospital is recognized for a program, so they're transferring their recognition over to a physician's clinic. So when they do that, they have to contact us. We have a report that they fill out to see if anything that would reflect them meeting the standards is changing, and if it is, and we require proof that they're still meeting the standards. So then the recognition gets transferred. They get a new certificate with the same billing group name that that physician practice is using to bill Medicare. They provide Medicare that certificate, and then they determine which NPI they're going to use. So at an outpatient hospital program, the provider of DSME can actually be the entity's NPI, but at a practitioner's practice, it has to be an individual's NPI. So what do you do if your DSME educators are all nurses? Because nurses' NPIs can't be used to bill Medicare. And Medicare gave us this language. Often the NPI used is not the provider providing the service for DSME. So a physician is usually identified, and their NPI is used to bill on behalf of the entire DSME program. And that's where we reached out back to Medicare then and said, well, if that physician does that E&M code on the same day as the DSME code, is one of those bills going to be rejected? And they said no. Again, last Monday, that was one thing that I asked, that they provide more clarification because it's confusing. And I actually gave them a chart. Hopefully it's more successful than my DSME and different program chart with different entities, and asked them to identify specifically which NPIs can be used. So there's no gray space. Thank you.